I think we'll probably all, including me, get the most out of this if you interrupt me and pipe in, and I will hopefully open up the floor to you guys to do the same, so that we can all stay awake. So I named this Team Training and Crisis Resource Management to errors human but. And my hope is in this hour-ish of time that we'll all get familiar with the history and current call for team training with crisis resource management as the model for it, that we'll know some of the theory behind and the evidence for training in these areas, and especially simulation-based training in these areas given the forum we are in. And then we'll appreciate some of the challenges with designing, implementing, and evaluating these training programs and our participants. And I think that's where some of your all experience will be interesting to hear, since I'm not the only one who has published papers related to crisis resource management in this room. So I know you have all heard this ad nauseum, but I don't think you can have a discussion about team training without bringing up the infamous Institute of Medicine report in '99 that estimated up to 100,000 deaths per year are secondary to avoidable medical error. And then up to 80% of these errors are due to issues with communication and teamwork. Evidence has continued to accumulate since then. The Joint Commission in 2008 listed communication errors as the root cause of 65% of sentinel events, with 3/4 of these resulting in death. So these are just two examples of the growing data telling us that we are not very good at things like communication and teamwork in medicine. This has led to lots of calls for, to use a medical education term, remediation, with these safety-related organizations calling for interdisciplinary team training programs, especially in critical care areas like the ED and the ICU, where many of us here practice, and the OR as well. And these organizations actually recommend using the principles of crew or crisis resource management, depending on your perspective, in simulation-based training, with the goal of making us a high reliability organization. And it was actually good for me to spend some time rereading this literature, because it sort of reestablished my theoretical foundation for some of these ideas and terms. And I thought we should spend a couple minutes going over some definitions. The definition of team is a bit intuitive, but I ran across this reference to Baker's definition a couple times. So I included it, and it is two or more individuals with specialized knowledge and skills who perform specific roles and complete interdependent tasks to achieve a common goal or outcome. Ad hoc team is a term that comes up a lot and is relevant to our practice areas, and it's this idea that it's a team that forms rapidly, has an abbreviated, limited lifespan, and usually those folks have a limited experience working together.
No kids.
So I will hear that this term ad hoc team come up a bit. I also ran across varying uses of the terms multidisciplinary and interdisciplinary, and it's interesting because I think, from my understanding of these terms, some folks still use these incorrectly. So I wanted to distinguish those. Multidisciplinary team means that you have multiple disciplines working side by side, only responsible for the activities related to their own discipline. So this is sort of the silo situation where you may have a common goal, but you're on your individual paths to get there. An interdisciplinary team is really, to me, the more relevant one for healthcare, where your multiple teams are working as a collaborative group towards a common goal. And this concept of an interdisciplinary team comes up because we'll spend some time talking about shared mental models and those sorts of things. And I wanted to throw in a definition of interprofessional, and Sam, since you might make it to more of the ITSP meetings than I do, to me, can you distinguish in your head a difference between the terms interdisciplinary and interprofessional, or do you just think they're used in different contexts?
Yeah, I don't really know. I mean, I guess to be interprofessional just means you have members of truly different professions with different traditions of training, but who face kind of issues educational otherwise that transcend differences in job description or schooling and training.
Yeah, that makes a lot of sense. So an interdisciplinary team could be an ED doc, a PICU doc, and a trauma surgeon who are from different disciplines, but the same culture of medicine and MD training. And interprofessional is that next step where you have the MDs and the nurses. And that is almost, that concept is almost more relevant to the team training, I think, that we're going to talk about. But interprofessional is a term frequently used for education, which is relevant to this topic and this idea that you have practitioners from different professions who come together and are learning from each other, about each other, et cetera, et cetera. So just a couple more definitions so we're all on the same page. What is team training? We hear a ton about it. What exactly is it? And this is a definition from a recent review article that sums it up as a systematic methodology for optimizing communication, coordination, and collaboration of healthcare teams that combines specific content, knowledge, especially in attitudes, but also skills associated with teamwork competencies, with opportunities for practice, formative feedback, and tools to support transfer to the daily care environment. So to me, that is the ideal of what team training is. And as we'll talk about, it is sometimes hard to get there because of how all-encompassing that definition is. A great distinction one of the papers brought up was that it is meant to be generalizable. It is not team building. Team building is a fad in and of itself. But team building is when you get an established team, you do some training, bonding for that team that gets transferred back to when that team works together elsewhere. But team training is more giving you skills so that you can go into different environments and work with different people and achieve these goals. So I thought that was a handy distinction. Crew or crisis resource management, and we'll talk a little bit about the difference between those, or at least where those terms came from, is really a popular adaptation of a shared mental model for team training. So it is a version of team training that has become quite popular. And the idea is, what it focuses on is teamwork clearly, but also the use of resources, equipment, and people to enhance safety and efficiency. And then the high reliability organization. This was helpful for me to actually hear a definition of, and then to read everyone's comments that healthcare is not necessarily here yet. Other high reliability organizations, aviation, some military practices, all of the other, and we'll talk about this more, areas where simulation is coming from and being used. But they are institutions where individuals working together in high acuity situations, facing great potential for error and disastrous consequences, consistently, and that's the catch I think for us, deliver care and positive results with minimal errors. So I think these various reports that have come out argue that we are not yet a high reliability organization and we need to work on getting there. And then in fact, maybe we're a little behind the ball of some of the other high reliability organizations out there.
If I could just interject, if you don't mind, I just wanted to,
Please.
Some interesting conversations with colleagues in aviation. And one of the very kind of pragmatic neighbors of mine who's a pilot currently flying for Southwest and has flown in the military, he says, the reality is our motivation is different because if we screw something up, we die. In medicine, the providers typically aren't on themselves at risk. So you can imagine there's obviously a lot of teeth gnashing and hair pulling about why can't we be a high reliability organization like aviation. Well, they've got kind of a different dog in the fight.
One thing that I heard on that angle from the sim world was John Coburn worked for a long time on a nuclear sub. When they had their simulations, anything that went wrong was reported as if it was a real event through the chain of command, and people were disciplined as such.
Yeah.
But we've never even attempted to do that.
Yeah, high
sims for the
stakes
most part.
testing is a little bit different in terms
Yeah.
of how high stakes are.
That led them to take the sims a lot more seriously.
Well,
I think we're also still in a different place because if you look at our simulation training, even in this hospital, we tend to be very learner dependent. So for example, all our simulation is done to residents for the most part. And then if faculty, they can come to the difficult airway days and stuff like that. And I'm not sure if there are requirements for that, but certainly how many of our faculty run our sim cases, or actually run through them and go through them, and if they did and do well on them, what would we say about that? It's very different where if you take the whole team in a military institution and run them through it, the guy running the team is very much involved in that.
Mhm.
And I think that you have to have that culture in order to really say that this sort of thing is effective.
But then simulation in medicine is much younger than simulation
Yes.
in other fields. And we do have to take that.
Yeah, it's interesting you bring up the running faculty level folks through simulation because I, for a while, it's temporarily on hold, but was doing some sessions for PICU folks, and we would bring in attending. So it would be attending, nurses, and RTs. So the actual team. And at one point, it created an interesting dynamic for a few reasons. One, I was then running scenarios for my colleagues, and most of the ones who came had roughly the experience I did, but from an education standpoint, it's kind of a different dynamic for me to be trying to help one of my peers and have them save face, that dynamic was unique. It's a little bit easier when the hierarchy is a little bit more traditional. And then they asked if residents could come, and I actually, in fact, they wanted a resident come to kind of use it for some remediation. And I said, that's not what this is about. Like, the point is that the PICU attending is there going through these scenarios because that's who'll be doing it in the PICU. And when you do it with a resident and the PICU nurses, it's an unnatural, it's the real dynamic, but it's not the dynamic that happens in true emergencies because the attending comes, but where the nurses know more than the resident.
Yeah.
And it just gets a little bit unusual, so those are awesome points. So how did we get to the point where there is ostensibly a mandate for healthcare teams to be undergoing team training and working on their CRM skills, and a talk about this topic would also not be complete without a reference to the plane crash. Tenerife, is that how you say it? That's how I say it, but I don't know if I've heard it said out loud many times. And this comes back to, I imagine you are all familiar with this, it still kind of spooks me out to hear about it. But this is the plane crash back in '77 in the Canary Islands where 583 people were killed. It's still the deadliest plane crash. And just to remind you, ostensibly what happened was, the usual sequence of events, the perfect storm, so to speak, where the usual airport they used was closed because of a bomb threat. A bunch of air traffic got rerouted to the Tenerife airport. They weren't used to this amount of traffic. They didn't have all the radar monitoring systems, and then the fog set in, and they were solely relying on audio, sort of their audio communication to move planes on the runway. And there was a Pan Am 747 on the runway and this KLM 747 where the sort of head pilot thought he was verbally cleared for takeoff when in fact he wasn't. And he went to take off and saw, the Pan Am plane came out of the fog at the last minute and they crashed into each other. And everyone on the KLM plane died and most of the people on the Pan Am plane died. So, you hear stories of how maybe the crew knew that they weren't cleared for takeoff and didn't pipe up as one of the learning points. Although, I'll be honest, I'm not sure how they could know that when everyone on the plane died. The black box, is that how they know it? But obviously a tragedy where almost 600 people are killed led to a lot of reflection and investigation. And initially, from what I understand, the aviation industry was using simulation more for their technical skills, and they realized that all that work wasn't improving safety. And again, not surprisingly, that most of the accidents were from human error, much of those related to communication and teamwork. So in the 80s, what I think was briefly called cockpit resource management and became crew resource management was sort of the NASA, the military, and the airline industry coming together to develop this type of training. And then in the 90s, us figuring out in medicine that, hey, maybe this is a good idea for us too. And it sounds like it wasn't just something that we were working on in America, because some of what I read quoted that the first time this was applied to healthcare was actually in Europe in the mid-90s. But then there was quite a bit of work in anesthesia in the 90s. Have you guys met David? Is it Gaba? Is that how you say his last name? I imagine. You've seen him talk or met him at some point. Okay. Aaron, you have. I think I've seen him talk. I don't remember where it was. But he did lots of this early work in anesthesia. And that's when we started to call it anesthesia, but called it a little bit more crisis resource management. And then that started to trickle to the other areas where you have unplanned, uncommon, high stakes events. You guys know the spiel, with ad hoc interdisciplinary teams. So trying to tie in some of those terms we were talking about before. But this is why we see a lot of ED and mostly ED and an ICU physician here, because we're the ones that we practice in that environment a lot, at least in terms of an environment we're focusing on using simulation for these kinds of skills seems relevant. So what exactly, so there's crisis resource management, which is, I think, sort of an approach and a model, but then you'll hear people talk about crisis resource management skills quite a bit. And that's really what I did, worked on sort of instructing and doing some research on as a fellow. So this is probably the first time I've quoted myself in a talk before. So I guess I've arrived. But the way that I defined it, after doing quite a bit of reading about it a handful of years ago, where I defined the skills as the generic behavioral skills needed to safely and effectively manage medical crises such as resuscitation. And I was doing, obviously, work in resuscitation, so that's why I put that in there. But to me, it is helpful to contrast the two. It's not the medical knowledge, as you all know. It is not the technical or procedural skills. And in fact, sometimes these are called non-procedural skills. And Sam, I noticed you guys in your paper, actually, I think you referred to them as non-technical skills at one point. I think that's a useful distinction. What exact skills are included within this construct varies a lot, depending on whose paper you read. But I think depending a lot on the context of where those skills are applied. You know, the skills, the way the task analysis sort of pans out in anesthesia looks a little bit different than critical care, looks a little bit different from the ED. And I think we'll get to this as one of the challenges of rating these is that your rating instruments inevitably reflect what you think the construct is, but then it becomes, I think, hard to translate things from one setting or rating instrument to another. This is what Gaba said in 2001, and I think this might have been his A Decade of Experience article. And I've seen this in a couple places where people actually split up the crisis resource management skills into two categories. And they have a category of sort of cognitive skills, which are on the left, and then kind of interpersonal and communication skills. So I've seen that distinction made a couple times, but I just threw this up at this point for an example of some of the skills, at least in anesthesia, that he thought specifically fell under crisis resource management. So for the decision making or cognition, know the environment, which is the situational awareness, that you'll hear that term, anticipate and plan, use all available information and cross-check, prevent or manage fixation errors, and use cognitive aids. Which, this is where it starts to get interesting to me when you really think about it, because, you make this distinction between knowledge, technical and non-technical skills, but there's a fair amount of overlap in them. And then for the teamwork and resource management, exercise leadership and followership, call for help early, distribute the workload, and mobilize resources. So that I would say is kind of the background of the theory, the call to action, some of the terms. I'm gonna transition to talking about sort of how we make this happen and what it looks like. But maybe I should pause for a second and see if you all have any thoughts or comments on what we've chatted about so far.
Followership. Are you going to touch on that later? I think it's an intriguing concept that I don't think we address much in training, and I think it comes up in the practicalities of many scenarios, particularly when you're talking about crisis and you've got a room full of cooks. And I don't think I personally have never been involved in training where you say you've got the red hat on, you're the leader. And some programs have gone so far as to actually distribute some sort of, label. It's a physical hat or a vest or something, and that it essentially tells the rest of the room, shut up, you're in charge. But outside of something like that, I'm not aware of anything where it's okay to say, yeah, you're a leader, but just not right now. You need to do your job as a follower.
Yeah, I will allude to the fact that that my experience evaluating these skills has always focused on the team leader, which I think is a shortcoming on some level, because this is more like you're discussing. It's more about teaching leaders. It's about teaching followers.
It's the flip side of the same coin, right?
Does that change if it's an interdisciplinary team versus a multidisciplinary team?
Do you think so?
Because in a multidisciplinary team, they tend to be the leaders of their individual teams coming together. So it's like a unified command versus a joint command, right, in fire. So is there a difference in how you would handle or evaluate that? For example, if I brought in a medical student, a PA student, an MP student, and say a mapping student into the same team, and we evaluate them, they're all going to be leaders of whatever it is they do. Is that evaluation going to be different because there's not going to be one? I mean, there has to be a designated leader for this to work, but they're all still leaders. Does that make sense? In an interdisciplinary versus a multidisciplinary.
Well, I guess it comes down to, I think my experience using these skills, and we are talking about crisis resource management, so I think this is universal. But my experience has been with resuscitation. And I think a rule of resuscitation is that you need a leader. And then if you don't have a leader, chaos ensues. It looks like you guys agree. But do all teams, can you have a team without a clear leader?
No,
You know,
because your chain of command won't work.
Well, I think you have a poorly functioning team, which you'll see in a lot of our
Yes.
resident-run floor codes. Is that part of
but
the
in a non-crisis, like let's say you extrapolate to a patient care team. So now we're talking about, I think, not necessarily crisis resource management, we're just talking about teams as they function. But let's say you talk about a patient care team, which in the PICU is physicians, nurses, so physicians, which include attendings and residents and maybe medical students, nurses, respiratory therapists, consultants who come in. So
You would
I
still
think
have
here-
to have a chain of command, and you would
Or-
still have to have an accountability angle.
Yeah, I guess I would argue that a lot of that is dependent on how clearly defined individual roles are and how kind of comfortable people are in recognizing kind of the divisions between roles and kind of the responsibilities within roles. Because I think when you look at very, very high performance teams in the military or, like NASCAR pit crews or whatever, that can get a particular job done very, very quickly and in a very coordinated fashion. The roles are so distinct that there's probably not someone saying, you go here, you go there, because it's kind of understood.
But there is going to be that one person who's going to oversee this entire thing happening, making sure it is happening at the right times.
Right. Yeah.
Right? And that person would be then considered a leader of that team.
Yeah. I mean, I think the management part, at least in my mind at this point, I've read about this stuff a lot as well. Kind of the management of crisis resource management is that there is kind of a someone has to be in a slightly stepped back position, and it seems like that role involves kind of a perceptual and integrative function of kind of recognizing what is going on, what are the salient features, and what is being done or not done, and then there's also kind of an efferent directing, kind of executive or whatever you want to call it, that is kind of simultaneously monitoring and then making certain things happen, whether that's done with a lot of words and a lot of noise and a special hat, or not. I think, and that's again where kind of clarity of roles and degree of familiarity can smooth a lot.
I don't know if I'm jumping the gun on this at all, and whether you're going to touch on it, but one of the things that kind of continues to kind of fascinate me in terms of, we're talking leadership, and you're talking about the efference of leadership. You got that person who's, I think we would agree, needs to be kind of situationally aware and kind of directing things, particularly with high variabilities. And we talk a lot about, the literature seems to speak to, closed loop communication and some of the kind of verbal pieces of it. And so we kind of understand, I think, the goal, kind of where we need to end up to be in this kind of high reliability. But there are a lot of presumptions, I think, on where we are all individually starting from, and I think that depends a lot on individual personality types. But at an individual level, as educators, I find myself struggling sometimes when I'm trying to have. And again, in emergency medicine, we tend to have. I mean, there's kind of that poster child of emergency medicine, right? Tend to be kind of loud, kind of. It's not hard to get our folks to speak up around the table. In fact, quite the contrary, is I need you to be quiet. No, that's hard, right? That said, there are a lot of other variables in there in terms of physical stature. I mean, as a medical student, I was often the tallest person in the room, and it would drive my chief resident crazy. We'd go to a code. There were gender issues, I'm taller and I just happened to be a guy, and she was in charge, and I made note. I was always in the back, and the nurses were deferring to me, and it was uncomfortable. It was uncomfortable at multiple levels. And how do you train, for that person to have a presence when no one can see you because you're, 4 foot and change or something, So it's those kinds of things I think we need to be aware of as educators, and how you speak to that. I don't know, but
that is an individual thing, because you haven't met Cheryl London, vet oncology. That's cool. Like yay high, looks like she's in 10th grade, long blonde curly hair and glasses. She'll clear a room.
Well, and I think there are interesting skills around being able to say, given that you might be kind of quiet, these are probably the ways that you need to kind of step up and manage a room. A little bit different than if you have kind of a different affect or a different personality or stature.
I've seen a quiet and short and slight of stature attending climb up on a chair during a code to run it, and it worked.
That was because she could see all of it.
Well, that's a guy. He was a very soft-spoken, quiet person, and he just climbed up on a chair. And it's like one of those CT scanner, just awful, chaotic code thing. Yeah. So, but yeah, there's that.
I just don't know that it's been studied or described or any way kind of piece of it where you're going to touch on, but it's just another variable to be.
Yeah, I think what we will touch on a little bit is a call for sort of doing your research, so to speak, before you implement a program like this. And one of the things that they focus on is a readiness assessment, which is essentially getting a sense of where people are starting from. But the example you came up with, which I think we probably can all, I can think of examples of standing there with a medical student and somebody comes up at some sort of gathering and they, introduce themselves to the male medical student, as doctor first, and but have you seen that implicit bias, the implicit bias sort of research? I think it's actually a research project it's Harvard, right? Have any of you not seen
The one
this?
that's floating around in our inboxes right now, it's the,
No, that's
There's
faculty climate
it's
survey.
faculty.
Right.
Yeah, no,
this
it's actually
is-
for faculty that are interviewing
Yes,
for faculty hires.
for
right?
recruiting.
Yeah, yeah, right.
It gets sent out ahead of time, I think,
Right.
before you go to your faculty recruiting session. But it's you're shown. I haven't done it in a couple of years, but you're shown a bunch of pictures and words. Have you guys done it recently? Can explain it better.
It's been a while.
But essentially, what it does is it shows you pictures and words and has you click on things and you sort of react without thinking.
Right.
And then at the end, you can get a sense, because I think they're sort of associating good and bad with like fat or thin or gay or straight or black or white or different differences amongst people where you can have subconscious biases, and that is an example of an exercise I think you could do with a group of people you're training in this area, because that's what that assumption is that person's making, right? The tall, deeper voiced, heftier, that's not a good word to describe you, but person is clearly a leader. Like, to me, that's an example of an implicit bias. So that's the training you can do. Awesome. And I guess to get back to the whole multidisciplinary versus interdisciplinary situation, I guess my take on that is, especially in crisis resource management, that one of the goals is, regardless of the team makeup, to have the mentality, to have the interdisciplinary mentality. To break down the silos, whatever the silos are, whether it's attending fellow med student, whether it's doctor, nurse, RT, whether it's surgeon, ED doc, PICU attending, that the point is to break down the silos and have this shared sense of your approach and your goals and those sorts of things.
We do kind of see it sometimes on our floor mock codes, and I don't know if this is something we'd be able to look at in our code blue assessments, but when the nursing supervisor from the floor enters a room while a code is going on, the nurses automatically look to and follow them and detach themselves from the physician management portion that's going on. It's oftentimes very inadequate because it's a resident standing there not knowing what to do and looking to the nurses anyway. And suddenly the nurses are taking orders from their natural leader and supervisor, who's better off organizing them in a lot of different ways, but not necessarily connected to the medical management that's going on for the resuscitation. I don't know if we have enough cases where they've actually walked in, but I've seen it once or twice.
Well, I think, like, in talking to ICU nurses, at least in kind of like cardiac arrest, they are very adept. That their skills are very sound. They're very comfortable in codes, and they kind of view part of their role as kind of reinforcing leadership of the resident who may or may not, resident fellow who may or may not be experiencing comfortable. And so it's this kind of, I think there's recognition that there should be one leader and at least in the code structures here, that's usually a physician, but that person may really be in deep water and not at all comfortable, and that they kind of view part of their role as kind of reinforcing or buttressing that leadership structure.
We see a lot when our residents defer to RT to manage their beds, almost constantly following the resuscitation. And at some level, it's probably okay, because they might know about it more than we do. And of course, we in the end have the right to order. But the leadership changes in those situations where somebody's an expert and everybody else is maybe not much.
Yeah, and I think this is probably I'll touch on this at the end, but I think we're doing a good job covering it now. One of the challenges that people talk about is the hierarchy in medicine and the different culture, and I think it would almost be easier if the hierarchy is even more challenging, I think, in a teaching hospital. Because the old-fashioned hierarchy, you kind of knew whether or not it's a good thing, you kind of know where everyone stands. When you have an attending level physician, a bedside nurse, a charge nurse, that's kind of the traditional hierarchy. The hierarchies within an institution like here, I think are that much more challenging for the reasons that you're talking about. Your leader is not necessarily the code leader that might be wearing the hat or that fills that role because they're the MD might not actually be the best choice or as prepared as they could be. Okay, so how do we make this happen? How do we, if we were to, I guess we'll talk about the royal we. When we are designing team training programs that are going to have a focus on crisis resource management, because that's what we do, where do you start? And it was interesting. What is Walter Epic in PEDS? I've read a little bit of his work. Have you guys heard of him? So he must be in PEDS because I've read a couple of his articles. This one from 2011 was a review article in Simulation in Healthcare, a supplement that I think was a supplement full of kind of consensus statements. And he was writing about the role of simulation in team training in healthcare. And it's interesting because he had all of these suggestions for how you should develop a team training program. And when I took a step back, I was like, he's talking about the principles of curriculum development. He's just not putting them in an educational theory framework. It was really interesting. So I bring up the infamous Kern book that some of you have probably thumbed through about developing curriculum in medical education. But what was stated in this simulation review article was the importance of the needs assessment. And this is the general needs assessment I think we have, right? That's we're bad at preventing medical error in healthcare. The needs assessment of the targeted learners clearly is where you get to know who you're actually working with in what setting. It sounds corny to say it out loud, but have goals and objectives in mind to this audience. But align those, and then even more importantly, align those goals and objectives with your educational strategies. And this is where we talk about where the role of simulation is and what are its limitations. And then, the sixth step is the evaluation and feedback. Simulation's great at tying debriefing. Formal assessment is another piece of it, and then so both sort of the formative and summative assessment of participants in the program. It was just really interesting to have this kind of light bulb pop up and be like, this is better shattering what you're saying. It's what we're all supposed to be doing, but it's very easy. It's very easy to forget when the ball gets rolling to take a step back and start at the beginning. So what should we be teaching and assessing? And this, we've started touching on this a little bit. There is clearly knowledge involved, and the medical knowledge of your ACLS and PALS algorithms is one thing, but even when you're focusing on crisis resource management and those skills, there is some knowledge you need to have, and this is the knowledge of other people's roles that's so clear to delineate the roles and have knowledge of what other people's roles and responsibilities are, and what your own role and responsibility is. There are lots of skills, some crisis resource management, and we'll touch on some other skills that people are sort of broadening out to. And then there's the attitudes part that's so crucial, and I think we, at least when I've done training in this area, kind of indirectly get at it in the debriefing, kind of talking through things. But things like, this is I think where the implicit bias comes in, implicit bias comes in. And then what are your attitudes about a team and how a team should function? And then there's this idea you hear a lot about where this all kind of gets lumped together to a shared mental model. And to me, the multidisciplinary approach is part of it, but it's the idea that you're all on the same page, so to speak, in terms of how you're thinking about and approaching and explaining things. So how do we do this? This is transitioning from what your goals and objectives are to more of your instructional strategies. And there is an impressive amount of classroom-based education that goes on in this area. And it can be, they'll sort of distinguish between information-based, which is just didactics, and then, tying in the demonstration-based videos, and I think of kind of the PALS videos that they show about these things now when they do that training. But there are a number of programs that have been established, some by the military, some by associated with the AHRQ. Have you guys ever participated in any of the sort of LifeWings, Team Steps type of thing? And in what context, I'm curious?
We were applying for a grant back in New York to kind of integrate Team Steps training into our code team resuscitation training in our hospital system, which was abysmal. And so we went through all the Team Steps.
System or the
Both, actually. We went through all the associated training for Team Steps just to get a feel for it, and never ended up getting the grant, actually, but did a lot of the training work, so I'm familiar with all their penguins and all their little material that they have associated with the training stuff.
and you were getting trained to be a trainer, essentially? Yeah. Okay. Did you find it helpful?
I thought it was good. I mean, it was a very nice breakdown of crisis resource management, and I think it was described in a way that was very useful, particularly for floor nursing staff and people who may not be too familiar with critical care, because they broke down sign out communication and back and forth interactions with critically or sick patients in a way that was really kind of easy to understand. And all the same lessons that we taught were well integrated into that course.
Cool. And was there any simulation components to it?
That's what we were trying to come up with on our own. There were scenarios, like, just talking through scenarios with individuals, but nothing that involved actual equipment that would be used.
Okay, that's my impression of it, so that's good to know.
I think that OHSU is a teaching site for Team Steps that has kind of taken on a sim specialty tweak to Team Steps, because the program kind of writ large is not sim-based.
Mm-hmm. And we'll talk about a study that tries to do that as well. LifeWings, I saw some talk of LifeWings also, and I think the PICU group went through that before I came here.
Some years ago.
And we have a lot of LifeWings. The trickle-down effect that I have seen is a lot of checklists. Do you have the LifeWings checklist for the, closing an open chest at the bedside?
Right.
There's just like a different checklist.
And unfortunately, I think part of the legacy of that was I don't think that was perceived as going particularly well, our experience with that, which kind of set the stage for being very reticent to accept a probably more adoptable program like Team Steps.
Interesting. So that is the classroom-based instruction piece of it. Then obviously there is simulation-based training, and I didn't put much on this slide because it's what we're talking about. A good kind of classic, have you all run across the anesthesia non-technical skills work at all? Yeah. You've seen the scale. Yeah, so it is part of and it's out of Europe. It is from the discipline of anesthesia. I am most familiar with it, and we'll look at their rating instrument, but they have a whole training program that's based on crisis resource management principles. But what we know theoretically, and we'll talk a little bit more about the evidence, is that it doesn't make sense to do either of those things in isolation. I don't think. Because if you think about this from an educational theory standpoint, a mixed model to me makes a lot more sense, because you need to match your strategies with the type of learning that you, and this is what Kern stresses a lot, match your strategies to what your goals and objectives are. And then, incorporate those principles of experiential learning and deliberate practice. And I think I missed it, but Sam, did you talk about educational theory in the context of simulation way back when?
Touched on it. It was mostly a talk about Kern, but yeah.
Okay.
we did talk a little
No
bit.
wonder everybody nodded their head. Okay, cool. I think you guys have some framework for this, both because of this and in general, because of the work that you do. But to me, team steps makes a lot of sense when you're talking about principles. So the didactic, classroom-based, when you're talking about knowledge of roles, when you're talking through attitudes, that's to me you can do in the didactic classroom setting. I think you have to practice the skills. I mean, you guys aren't going to argue with that. And that's where the simulation really comes in. You tie in the feedback and assessment with the debriefing, whether you incorporate video or not. But that's your sort of feedback and assessment phase. And then the key part of the model that I think we'll talk about in a little bit is this whole need for recurrent training opportunities will come up. Because I think, just like we know for lots of other skills like PALS and ACLS, there's the, why am I having a word finding issue? I don't want to say degradation of skills, but, you lose your skills if you don't practice them. These, if you do an isolated 3-day workshop, but you never talk about it again, it's not going to have a lasting effect. So we're going to spend a couple minutes talking about evaluation. Any thoughts on a little bit of the theory behind what these programs should look like? Or does it all to this group seem quite obvious that this type of a model makes the most sense?
I think there's a little bit of preaching to the choir. Right?
Yeah.
I think we're all here because we are likely to be on a similar page. I think that I'm sensing you're going is being able to design a curriculum that is mindful of that skill atrophy piece. And this is really Sam's big grant that unfortunately HRQ doesn't look like they want to fund. But really being able to kind of design a curriculum that you are able to revisit the core principles on a regular and much more frequent interval than would be your usual merit badge, ACLS, PALS, ALS. Come back in 2 years. Good luck out there in the meantime.
I would add on to that. I think like the American Heart Association, would say, oh yeah, we're doing this. To get your ACLS card, you have to run a mega code, and we do sim, and aside from the huge issue of, just like here's your card, see you in 2 years. There's also the issue of kind of like your example of the resident or medical student running the simulated resuscitation with the PICU nurses, where they really wouldn't be in that specific role. ACLS kind of treats everybody like they're the same. So you have, a floor nurse or pharmacist or a respiratory therapist who all of a sudden is running the code and kind of interpreting the rhythm and calling for the meds and doing things that in reality they would never do, and that they don't feel comfortable doing. So there's a real lack of specificity to the training.
Yeah, I mean, you lose a ton of a certain type of fidelity in that instance. Yes.
I think that one of the problems that happens at academic institutions, which I think is less so in the community, but really has to get sorted out, is this training oftentimes skips the how to decide who the leader is. So it kind of gives that stamp already and says, you're the leader, how do you do that job? When really, I think a lot of our big problem is in a training institution, you have all these people of different levels, and oftentimes the last person to show up might be the person you wish was there first. So how do you, as for example, the R2 in the medical ICU side, who is often the code leader, how do you take charge in that situation? Or how do you give up control in that situation when you're the wrong person to do the job? And we kind of ignore that. Yeah, well, yeah, you can't just take the hat off and give it to someone else. But yeah, I see that.
Well, and then the piece of how do you learn
Yeah.
where does learning how to do this come into play?
Yeah.
And how do you sort of lead it, but then sort of also have somebody whispering sweet nothings over your shoulder about what you should be doing?
There's a lot of simulation work that goes into field work that does handle stuff like this, like in fire and military. They do a lot of the initial command versus who's taking command later, and then when there's transfer of command later, and you go through these phases. And they've become very good at doing that and developing simulations that take it into account, and we use those all the time. Not
Yeah.
so much in our limited, smaller simulations.
Right. So for the, Hicks and the other kind of disaster areas.
Yeah, we have
Yeah,
that,
whole
that's part of the
infrastructure, we do
training,
that,
yeah.
right. But that's about as close as it gets to this side of the hospital walls.
I do think that this is an interesting limitation of a lot of what I have seen done in terms of simulation training, whether your focus is on crisis resource management or other skills, because what you all do on the with your mock codes dispersed in situ throughout the hospital, and the debriefing, as I understand it, it's not a ton of crisis resource management.
We kind of do the in-person debriefing in two, there's one that's very much about kind of technical skills, just doing CPR better, managing airway better, kind of how you turn on the defibrillator, make sure
Yeah.
it's attached to the set, very like basics. But then we try to do kind of the leadership and communication talk. But again, it's kind of about generic stuff, closed loop communication and identifying your role when you come into the room. We see a lot of the anesthesia or pharmacy folks kind of slinking around and not really, no one knows that they're there, until they're,
Which might be their intent.
yeah. Well, I think that is, the hardest piece to teach is that, it's that kind of like step out onto the stage, and be a slightly taller, bigger, louder version of yourself, because you have to be, not that you want to be.
And I think, we may or may not reach into the challenges slides as we chat, but I think maybe part of the point about the slide is like, yes, we all know this is what it should look like, but it is really hard to do. It takes a lot of time and a lot of effort, and from what I know of what you all do in situ, like you really maximize your experience with the emails afterwards and sort of the video teaching that you do, but this is time consuming and resource consuming and all those things. So let's talk briefly about evaluation, because I know this technically goes to 1:30, but you guys frequently wrap up earlier. Is that true? Do I need to speed it up, or you guys are okay? Okay. What's to evaluate? I wanted to talk a little bit about, because that's where some of us have experience, and to me it's one of the biggest challenges. And I think a lot of my experience is evaluating individuals. I'll be interested to hear if some of you all have experience evaluating the team as a whole. I have used the data about individuals to help evaluate the program. And a lot of folks will talk about evaluating on an organizational level, like the culture of the organization. I don't have too much experience with that. I figured this was a good point to remind us of Kirkpatrick's model. I'm sure this comes up on and off in your talks here, but I think it's a helpful model for evaluating training programs. And this idea that the easiest but softest level of evaluation is reaction. What do the learners and participants think about the experience? Level 2 is learning. What knowledge, skills, and attitudes have they acquired? Level 3 is behavior. And what's interesting, this is from Kirkpatrick's website, is that level 3 is to what degree do participants apply what they've learned during training when they're back on the job. But we kind of assess their during simulation activities, which isn't necessarily back on the job. But folks will consider, if you evaluate their performance during simulation activities, to count as level 3. And level 4 is sort of the pie in the sky outcomes of, does this actually make the medical care we provide any better for our patients? So we won't spend much time talking about level 1. I'm glad that other people are old enough to know who this is.
I'm laughing by myself.
But, I mean, I think we all know simulation is fun. So if you use simulation to do team training, people are going to like it. It doesn't mean a lot.
And that's the kind of the state at the beginning of using simulation of all the researchers. How much fun did you have?
Right. I mean, it is the easiest to obtain.
Yeah.
And we
Fill out
know
the
it,
survey.
and it's the most positively reinforcing to obtain. But it will not get you published anymore, I guess
Right.
is the gist of that. So level 2 is it talks about sort of the learning that happened. And one of the measures, and this is a trap a little bit that I fell into, the next softest way of looking at the effect of a training program is how it affects individuals' confidence or self-efficacy. And I like self-efficacy because it sounds fancier. Some people don't know what it means, so it must be fancier.
Definitely more academic.
Yes, exactly. But it is an individual's, so it's like confidence, but they differentiate it by saying confidence is your general, like, I'm a self-confident person or I'm an insecure person. And self-efficacy is more context specific. So it is your confidence in your ability to do something in a specific context or a specific domain. So I, in a roundabout way, so I, as a fellow, wanted to look at the correlation between self-efficacy and performance. There's tons of, if you lump self-efficacy as a form of self-assessment, because on some level it's like a pre-self-assessment rather than sort of a post, how did I actually do self-assessment? But there's tons of literature saying physicians are bad at self-assessing. A lot of the studies looking at how physicians are at self-assessing aren't the best studies. So I think that there is actually some correlation between self-assessment and performance, and you can find it if it's within a fairly robust research context. So I wanted to look at the correlation between self-efficacy and performance of crisis resource management skills within this program we were doing with the residents at UCSF. Only to realize that I needed a validated tool of self-efficacy to do that research project. So then, that kind of
build the tool.
Exactly. So then it became building a tool. Which was great. It was my fellow project, and that's how research goes, right? It takes you on paths you don't expect. And there is a lot of theoretical argument that self-efficacy and resuscitation skills is relevant. I mean, think about it. If you walk into that room and you feel some self-efficacy, you're going to introduce yourself and maybe even stand up on a chair. And if you don't, you're going to go hide behind the code cart. And that kind of sets the path for what you're going to do in that situation. So we ended up with this 20-item instrument on a Likert scale, and did show some correlation to performance. The interesting part of developing the instrument was, we did a factor analysis on it and essentially came up with different domains of crisis resource management, which of course mapped to none of the existing tools, but I think that's the way this goes. So I do think there is some role of tracking self-efficacy in these training programs. But I will admit, after I did that, I moved on to performance because it was a higher level of evaluation. You can also test knowledge. I mean, sure, heck, you could give them a test on what roles and responsibilities are. And attitudes is interesting. It makes sense to me that attitudes should come under learning, but we'll talk about how people try to kind of move it up the scale a little bit. Level 3 is, to me, where it starts getting real, and that's where you're actually looking at participants' performance. And I have only done this for team leaders. This is, and I thought I would throw out a couple tools. This is the ANTS instrument from Fletcher, this group led by Fletcher. And they did a pretty robust method of developing their instrument. And the blue shows up a little bit light. But essentially they came up with 4 categories: task management, team working, situation awareness, and decision making. And then they came up with a bunch of elements within those categories And what I liked about this tool, and you're not meant to read this so much as just to realize they had very specific definitions of what, for example, situation awareness meant, the 3 elements, what those meant, examples of good practice, examples of poor practice. So in theory, to me, this is how a rating instrument should look. And then this is kind of how it pans out, where you have the 4 categories, the 15, I think there are 15 elements. And then they rated on a scale of 0 to 4, and I guess N to 4, where N is not able to assess, so essentially a scale of 1 to 4. When we use this, we translated to a scale of 7. We found it to be easier to have more distinctions, and somebody had published doing that before us. So we applied this to essentially critical pediatric simulated resuscitations. I don't always call them mock codes because not everyone got compressions. And did not actually, and I don't know if it's because it's was designed more for the anesthesia domain, although it had been applied to critical care before, we didn't find this super user-friendly. And I think we got decent results if we gave a mean score for the categories in terms of inter-rater reliability. But there were a few that we just couldn't assess in those situations. This wasn't our favorite tool. Did you?
What kind of training did your raters receive?
So we used 3 raters for both of the studies where I rated performance, and we probably had 2 sessions of going through a few scenarios and rating them together and discussing that. So something, I'm sure if we had met 10 times, we would have been better, but I think for both of them, we had a couple sessions where we went through some scenarios. But 3 raters to get results that we thought were publishable. These ANTS folks have a bunch of spin-off instruments that I haven't worked on for surgeons, scrub practitioners. I like the names, but I couldn't really figure out what they stood for. Like, what is split stand for? What's that?
It's British, you can't really understand.
Maybe it's just the way they spelled it. I mean, SP must be scrub practitioners. I'll admit, I didn't go back and figure it out.
Leadership and non-technical skills.
Nice.
Oh, you're good.
I'm out.
And this might be,
Look at those lucky.
this might be non-technical skill,
I have no
non-technical
idea.
skills for okay. So lots and lots of work done on this instrument, probably to me the most robust kind of development and evaluation of it, but in my limited experience, not so user-friendly on the ground. And then we also, for that first study, when we were looking between the correlation of self-efficacy and performance, we used this Ottawa GRS instrument that you guys have used, right, for your study. The interesting, so it has a different way of breaking down the construct. They have 5 items. They used a 7-point scale. And then they had the overall score, which is always interesting to tie in what people do with overall scores. But it ends up looking like this, where you give an overall score and then your 5 other scores for your 5 other domains, the scale of 7 that I referred to, and then some anchoring behaviors, which again makes it a little bit more, I think it gets you better results on the other end because it helps keep the raters on the same page. But we also used 3 raters. We didn't throw out anyone's scores, and found that we did pretty reasonable, I think, in terms of our inter-rater reliability.
So were the ratings real time or video?
Good point. We did video.
Okay.
And did you guys do video for your rating?
They were real time.
Which is logistically, so much of this is if you're really going to have a program trying to decide what's academically rigorous and sufficient versus what's practical to actually get the job done, and there's trade-offs in all of it. I have one question for you though, in your, going through the rating scales and kind of shopping for them.
Mm-hmm.
It strikes me that they're kind of just broadly speaking, there are the rating scales that, with all the pros and cons of anchoring and having the descriptive pieces, but just kind of, to me, semantically, there's the ones that have a middle score, So an odd number with
Yeah,
a middle
right.
4,
Mhm.
right? Versus the very first one you showed, that was basically a 1 to 4, which forces you on one side
Make it
or
distinct.
other of average. And I think there's a certain psychology in that, right? And I would presume that it's kind of intentional. I don't know the literature behind it, but it's always kind of made sense to me to have a 5 or 7-point rating scales because, there's a certain kind of mentality of convergence to the mean, I guess, of the raters. And I don't know, do you have thoughts or did you come across that in your work to kind of make a decision or
I wish I could speak more intelligently about it because I do think it's an interesting question. I just know that it seems like most rating scales I run across have that middle number. Have you?
I feel
have you guys learned much
uncomfortable when I
about
look
this?
at a rating scale that doesn't have a middle number for some reason. I was like, I don't want to give them below, but they're kind of average, but that other one is above average.
We talked about this in another journal club a few weeks ago with like Pat Romano and and
Got interesting.
yeah, I mean, I don't think that they really came down on one side or the other. I mean, I think in terms of your results, there is maybe a desire to make people to commit to something generally positive or negative. But I suppose, even if you select, all 4s for a given individual, they're still relatively stronger, say, than someone that has this battery of 3s and 2s. So they didn't see a neutral option as an inherent
Pro or con.
or strength.
But they did refer to the 7-point scale being something that's been reasonably well validated in some other fields of research because of the way people distinguish good and bad.
Humans can kind of distinguish 7 of something.
Right.
7
Like 9's probably pushing it a little bit.
temperature or
Whatever. Right, there's a psychology.
Now, I do have one question on this rating though, where the raters, did they see like 3 or 2 folks first and then go back and rate, or did you rate from the first person they saw?
So within the study setting, so I guess big picture, I think, and Erin, you're alluding to this, rating these skills to me is tough because you really need to train and we, with a moderate amount of training needed 3 people in order to get scores that we felt were valid. And that's really realistic. It's probably unrealistic to have 3 raters show up at all your mock codes who can just stand there and rate and not do anything else because you have to pay close attention. And videotaping and doing this at home also takes time, which is what we did. Because most of us, I think, watched them twice to make sure we caught everything. So we trained outside of the study, like on other videos first, and then individually, I think I'd send out a series of them, but I think most of us would then watch video 1 and rate it, watch video 2, rate it, watch video 3 and rate it, watch video 4.
But you had rated several things before that. So
Yes,
that
to
was not
practice.
the first set.
Yes,
And in the scenarios, it was like a team resuscitation.
yes.
Was the person being tested just the leader? And
Yes.
the others were Confederates, or was everyone else?
No, it was like second and third year residents. And because they were studies and we needed to consent people, designated the team leader ahead of time. So we would go through the list of which residents were going to be at the mock code. I would see who wasn't in the study yet. I would approach them beforehand and say, hey, you're designated to be the team leader. Will you participate in the study?
Congratulations.
And then, but I mean, do you guys have any experience rating the team function, the team as a whole?
I mean, for the qualitative study, that's basically what we're trying to do. This is kind of something that Erin and I have talked a lot about, like with a lot of these kind of team leadership assessment tools. They're very focused on one person's perspective, and they're also largely kind of intrapsychic, phenomena about decision making and things like that.
Like what their situational awareness is.
As if we could like see
based on what
inside
they're
their brain.
verbalizing. Yeah, exactly.
And so there just are some kind of awkward things about it, and and sometimes the team is not really a team, it's like a bunch of actors playing roles and then one person who's like kind of put on the spot. Or whatever. So there's like the team dynamic itself is kind of artificial. It sounds like it was not that way for your scenarios.
I mean, it was artificial in the sense that second or third year resident probably wouldn't be leading the code, because there were picky fellows in-house, but there weren't any Confederates in the scenario.
And like for the qualitative study that we're doing, which does involve, like Joe Barton and I do this video review part of it, we kind of have certain, kind of technical and non-technical phenomena that we're like looking for, kind of how is CPR being done. But even that, for example, transitions over multiple providers, and sometimes it's being done well and done poorly, and it's a dynamic kind of it's a story that unfolds in lots of weird little chapters. And so I would say in that respect, we are kind of trying to look at the whole team. We're kind of deconstruct it, but looking at everybody's role.
And I would just dovetail into this because I think the work that Sam's doing in this regard is actually, to my knowledge, fairly unique, because he's really taking a sociology's perspective as opposed to a psychologist, kind of what you described.
Well, that's cognitive psychology.
Yeah. The other thing I would add is that there's a lot of interest in this area, if for no other reason that a lot of our professional societies, both in simulation but in emergency medicine, the sim wars concept. So seeing these pop up at all these meetings where these teams will come travel together, they'll have practiced. You took our team last year, right? So to the Seattle course, and you basically are thrown on a stage with an audience, an actual kind of, so there's this entertainment value of it. And one of the scenarios was somebody has a crisis on an airplane, and you just happen to be as a team happen to be riding on this airplane, right? And you have to
We probably haven't on the way to Seattle. I mean, when I go to Pete's conferences, sometimes they're like 5. I'm like, Robin Steinhorn's going to be sad if this plane goes down, because there goes like 10% of her pediatric department.
But there's a cadre of judges, so there's I think 3 judges that probably without any other tools other than to say, no, that looked pretty good to me. So I think there's a lot of interest. I don't know if there's actually any hard and fast criteria or tools that people actually use for a global team.
But I mean, theoretically, to me, that's, if you're going to look at performance, that is who you should be looking at, right? Because we just had a discussion about what's the role of the team leader, and it's not just about the team leader, it's about the followers. You're supposed to be, to me, like, the goal is that you are one organism. And like, somebody's the endoplasmic reticulum and somebody's the nucleus. So like, you are one organism. And you should be looking at the functioning of the organism itself, not how well, I'm not going to pretend to try to remember what an endoplasmic reticulum does, but I think that is, what's that?
I think, did you look at the stat tool at University of Washington? Because that was supposed to be a team rating tool
I
for
did not.
pediatric resus
I did
that
not.
they've been using for since 2009 maybe. And
Oh, yeah.
try to revalidate it every once in a while.
You said stat.
Stat.
Okay.
STAT.
I probably didn't back then because it was probably right around that time.
Yeah, sure.
And then, I mean, the number of tools has sort of ballooned like everything else. Real quick, the level 3 level of evidence for these programs is where people will start to talk about the safety culture or the climate survey also falling in as kind of a performance measure, which I think is interesting. This Weaver review, and I guess what they're getting at is how do you take what you've learned back to your setting, and what does it mean about the climates that you practice? What is the climate like that you practice in as a result of this training? It felt like a little bit maybe of a stretch to me. Maybe I wasn't understanding it. And then the level 4 is what are your clinical processes? I wasn't quite sure what they were talking about, but this makes sense to me. Like, what's your compliance with antibiotic prophylaxis? What's your incidence of case delays? Things more that get associated with possible morbidities, but how you're practicing. Does your team function better and you get your antibiotics in before the surgery more quickly? does everyone show up to the OR on time because they realize you're part of a team and you don't want to keep each other waiting? And then the patient outcomes. So real quick to where we are now, because there's one study that I think kind of highlights a lot of these issues. This is interesting. These are the PubMed results. It's tiny, at least from back here, but the number of patient papers in PubMed with the team training and related word search. With the early 2000s, less than 20 papers a year, and now, I think the last year was 2012, up to 100 papers a year. And if you think that's a couple years behind of what's happening, there's this tremendous growth in publishing about these programs, and clearly, I think, what's happening on the ground. And then lots of review articles about whether or not it works. So we've talked a lot about theory. It makes perfect sense. I'm preaching to the choir. But do we have any evidence for it? And the gist of this is going to be that lots of people are looking, but it's really hard. And we talked about this, I think, a couple months ago. It's really hard to design trials that are going to give us this sort of robust answer. And maybe there are other ways we should be looking at it. But this one review article in the BMG Quality and Safety about team training in healthcare said that there's decent evidence that both classroom-based and simulation-based works. They found a number of studies with level 3 and level 4 outcome data that they really stressed that what this program, it needed to be a bundled process. And again, readiness assessment and preparation to me is a little bit of the needs assessment. Interdisciplinary learning activities, of course. Ongoing measurement and feedback, of course. But what they stressed too was the checklists. A focus on how you transfer this to everyone's practice, and then how you maintain it there, which I think is a big piece. Where exactly does simulation fit in? Lots of people are looking at this too. The study that this review article highlighted, I thought was fascinating in what it demonstrated. So, you always know. Well, okay. So this is. It was published in the Joint Commission Journal, and they were comparing. It was a small cluster randomized trial in 3 relatively small hospitals.
I didn't know the Joint Commission had that.
Yeah, neither did I. It wasn't defined either. Over 2 years, and one hospital was a control. So this was related to perinatal outcomes, delivery, emergencies. One was control. One had just team steps. And one had team steps plus in situ simulation. So there's no simulation standing alone. That's probably okay, because we probably shouldn't do simulation in isolation. So they compared those 3, and there was a 37% improvement in perinatal morbidity at the didactic plus simulation site. It was in situ simulation.
Do you know anything about the intensity of the intervention, like how often?
That is the key.
Yeah.
So there was no change in the control, and there was actually a non-significant decrease in the didactic, but it was non-significant. So they said improvement when you added simulation, but the didactic group had 1 session, and they called it an abbreviated team step session. And the didactic plus simulation had 11 sessions over a 2-year period of time. So
Kind of a straw man.
Right.
So it's true. It's better than nothing. Now we know what the Joint Commission publishes in their journals. I think it's just an example of how it's really hard to do research in this area. I mean, this study clearly took quite a bit of work, but you're essentially comparing isolated plus ongoing. At the same time, you're comparing control and didactic against didactic and simulation. So I don't know if that answers all that many questions, but I thought it was a good example.
Well, the interesting study though that could have been, you could imagine would be that same kind of structure, but really is if you're going to invest the same amount of time and energy into, arm 2 and arm 3 of that trial. So we're going to put 10 hours of team steps didactics only versus 10 hours total of didactics and simulation. and see what their outcomes are.
Yeah.
That's true.
Because you could reinforce.
That's true, that might
The
not
team
actually have been the hardest
over 2
thing in the
years.
world. The interesting thing, they did do a survey of the culture of safety, and they scored highly even before the training. So there wasn't a change in how they sort of viewed safety and teamwork in the study. So to wrap things up, because we are done, I think we have touched on many of these challenges. The costliness, that's kind of a broken record. Again, I'm preaching to the choir. The culture change piece, I think just delving into the culture is such a big piece of things. And again, this is where qualitative work makes a lot of sense. We talked a bit about the hierarchy of medicine. And then, I think in a training institution, I just think our mindset is such that I think with at least in the PICU, we function, I think, in an interdisciplinary, interprofessional with that kind of mentality. But I think it is a new mentality for a lot of folks maybe out there in community hospitals that are a bit more cemented in the traditional hierarchy of things. It's very domain specific, and I think that's probably one of the challenges for a lot of this research. What works in perinatology may not work in the ED, may not work in a community hospital, may not work in a teaching hospital. And then the ongoing efforts, just because of the delay, I think we touched on that. I think
Nice.
that was all.
Thank you.
Thank you.
Of course.
Just a quick comment, question. The one thing I would say about, and I don't know that there's a good way to describe it necessarily or study it per se, but my sense is that when you're comparing kind of a didactic-only curriculum versus something that's maybe didactic and sim, I think we all kind of intuit that the simulation piece, the hands-on piece, is engaging in different ways to different people, right? And in some ways, I think it's very, a certain learner group is going to be very engaged and very much more able to accommodate a breadth and spectrum of material you're trying to teach, as opposed to the death by PowerPoint, blah, 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 talking about, right? At the same time, some people might be completely freaked out, and I'm getting the sense that a lot of times it's actually kind of the teaching old dogs new tricks part of the spectrum, where you're kind of potentially put in an embarrassing situation where your skills or knowledge might be kind of unveiled as being inadequate. Whereas you can kind of unveil the inadequacy as a junior resident, but the expectations are, hey, you're going to learn this, no problem. So that's kind of where my head is on a lot of this. Kind of a question that's quasi-related is just getting back to your self-efficacy description. And I wonder, when you were doing your work and kind of looking at the kind of the research base that's out there that has kind of really, I think, been, in my impression, it's kind of mixed in terms of how accurate clinicians are at self-assessment, as you alluded to. My question for you is, does that vary along the time spectrum, or the lifetime of their career? In other words, if your self-efficacy, is your self-efficacy more consistent, reliable, accurate, or whatever, when you're, say, a medical student versus when you're a resident versus when you're out in practice? Seems to me that, with the time scale, it might diverge one way or the other. Or,
Yeah.
I don't know.
There is some evidence out there, and this is not exactly related, but that and I can tell you could find a study that says anything, probably. But that the better you are at something, the better you are at self-assessing your performance. So that there is some work out there that there's a correlation between level of performance and how accurate your self-assessment is. And there's this group of people, so the flip side of that is that the poorest performers are the worst at self-assessment. And that is that's the group that you have to worry about,
Those are the
right?
killers.
Yeah.
as educators. And what actually, so then the study that I did after designing that instrument and looking at the correlation was we had residents, now that I work with med students, that's the word that comes out of my mouth. We had residents who were team leaders self-assess their performance. So we moved from the self-efficacy to performance. And we had them use the Ottawa GRS as a self-assessment instrument. And they ran the simulated resuscitation, assessed their performance at the end, and then like within a month met with me, watched the video, reassessed their performance, looked at observers, and then I had an interview with them about all of it. And as part of that study, I wanted to try to find a correlation between how well the residents did and how accurate their self-assessment was, and because it was qualitative, I didn't have that powered. But I remember finding that an interesting phenomenon. The most interesting thing about that study, other than what they said, was that most of them scored themselves lower after watching the video.
We touched on
Yeah, we
that
touched
a couple
on it
weeks
a couple
ago.
weeks ago.
And one of my graduate students is doing one on self-efficacy and simulation, and she's finding the same thing that for several areas on the tool she's using, the students were rating themselves higher before simulation, and then after simulation it goes down.
Yeah, so it's the effect of the simulation exercise, and I think,
There's an effect of seeing yourself on video.
Right.
but this was the effect of actually seeing yourself on video after
Yeah, now
fact, and they
hers
were
was
all like-
not, because they had not seen themselves.
Yes, and they were all like, oh my gosh, that's what I look like, that's what I said.
The first study is
Skill level.
more about your
That
thought
she goes
process,
up.
watching it through your phone.
Well, or it just points out
From another man.
They have
I bet
for the poorer students, maybe. what
The
they
other
don't know.
interesting thing is when the observers rated them higher, they disregarded the scores. They said, that's great, but that's not what I think. I just watched it. I deserve 3s. That's great that they thought I deserved 5s, but I just saw it. It's not that good. There's some interesting, almost counterintuitive, like that felt a little counterintuitive, because there's this idea that you,
And these are junior year learners, though. These are all students.
these were second and third year residents. So there's the idea that there's your self-preservation, and when you have an image of yourself, and when when you get conflicting data that's negative, you disregard it to sort of protect yourself and your self-image. But this was more, they had a relatively negative self-image of themselves, and when they got this positive data, they sort of, on the scale of what they were using to come to their conclusion, they kind of knocked it down a few notches because it didn't agree with how harsh they were being with themselves.
Was that dependent on outcome?
Meaning,
Like a good outcome versus a
Yeah,
bad
just the
outcome?
simulation.
Right,
I mean,
right.
you've done really well, but with a bad outcome?
not really, but
Just
again,
so-
there were just 16, so some of those distinctions were harder to make, because the interviews took so much, it was smaller.
Thank you, Jen.
That's great.
Thanks.
Great.
Thanks for